Hi guys, in this video I'll be reviewing equine thoracic ultrasound. We'll talk about the advantages and disadvantages of ultrasound, the general approach and technique, and common findings seen on ultrasound of the chest. While radiographs of the thorax are technically possible in large animal patients, ultrasound offers several advantages and is more commonly used. Ultrasound is especially valuable for peripheral lesions or diseases such as pleuropneumonia or surface abnormalities. The advantages of ultrasound are that lesions can be localized to either the right or left side of the chest. Ultrasound is sensitive for qualifying and quantifying pleural fluid. Ultrasound offers good cranial to ventral visualization. It can be used to identify prognostic indicators and monitor for disease progression, and is applicable for portable and field applications. Some of the disadvantages of ultrasound are that the ultrasound cannot image through aerated lung, so parenchyma is not visible if the periphery is normal, potentially hiding lesions deeper within the lung. There is a learning curve associated with using ultrasound and performing ultrasound of any body part. And then there's always the cost of equipment. However, due to the shallow depth and the lack of necessity for really good detail, just about any ultrasound can be used to ultrasound the chest in a field situation, even if all you have available is a rectal probe and a repro ultrasound. Our general approach to ultrasound of the equine thorax is in the standing horse. You can choose to either use alcohol or clip the area and apply an ultrasound gel. Remember that horses have a large lung field extending from the 17th all the way up to the 4th intercostal space bilaterally. For this reason, we often choose to forego clipping to save time and the horse's patience. You want to use a systematic approach to be sure you scan each area of the visible lung field. I prefer to work in a caudal to cranial direction to be sure you get each intercostal space going forward. We hold the probe with the marker pointing dorsally, oriented in a transverse plane along the lung, in between each rib. We scan from dorsal to ventral and watch a complete respiratory cycle in each scan window. Remember that horses have a low respiratory rate, so you need to be patient to see their lung moving in and out with each breath. This is the image we expect to see of a normal lung. Remember, our marker on the left side indicates dorsal. The most superficial part of the image is going to be the skin. Underneath that is the intercostal muscles, which are a mixed echogenicity. And below that, we see a thin hyperechoic line of the aerated periphery and reverberation artifact below it. When you increase the depth and frequency of the probe, you will see more reverberation artifact, but you still can't see past the aerated surface of the lungs. In this image, we also see the two adjacent ribs with their acoustic shadows deep to the rib. Reverberation or multiple reflections occur at highly reflective interfaces, such as muscle to bone, brain to bone, and soft tissue to gas. When the high-intensity ultrasound beam is reflected back to the transducer, hits it, and is reflected back to the tissue a second time. We see reverberation artifacts at a highly reflective surface, like the aerated lung. The initial ultrasound wave generated by the transducer hits the highly reflective surface of the aerated lung and generates the hyperechoic line of the pleural surface. However, it comes back to the probe with so much energy, it bounces back off the probe and goes into the tissue again. The machine does not recognize that this phenomenon is occurring and assumes that because it took the wave a longer time to return the second time, it should plot a line at a depth deeper to the original wave, resulting in a hyperechoic line deep to the first line. This cycle keeps repeating, resulting in evenly spaced, progressively less hyperechoic lines as the energy is gradually attenuated by traveling repeatedly through the overlying tissues. For a refresher on the physics that the ultrasound is using to generate these computer images, please see my video on ultrasound image generation. Comet tails are closely spaced reverberation artifacts caused by multiple reverberant reflections from irregularities in the pleural surface. The irregular reverberation pattern is closer together and begins to coalesce into what appears as hyperechoic streaks within the deeper tissues of the lung. Comet tail artifacts are a nonspecific finding that may or may not represent an active disease process. Wide coalescing comet tails or an increased number of comet tails may indicate more severe disease, such as interstitial disease or acute viral pneumonia. However, we also see some comet tails in older horses with age-related changes to the lung surface. Remember that comet tails are a nonspecific finding, and we need to consider the rest of our clinical picture to determine the differential list for the individual patient. Visible lung pathology appears as areas of non-aerated lung. Ultrasound can image through these non-aerated areas because they behave like soft tissue and the pleural surface does not reflect until you get to a normally aerated portion of the lung. Focal consolidation appears as a hypoechoic region on the lung surface, which may or may not have comet tails radiating from it. Here you can see this small, round, focal area of hypoechoic tissue with a pleural surface reflection deeper than the normal pleural surface on either side of the consolidated region. As consolidation progresses, you see tips of non-aerated lung that are soft tissue echogenicity within the pleural space. This is often referred to as hepatized lung because the appearance is similar to the liver. This is an excellent example here where we see an area of hepatized lung on the left side of the image. With some adjacent gas echogenicities. And then we see the muscular tissue of the diaphragm. And deep to that is the liver, looking very similar to the hepatized lung. Here we see an example where pressure from the fluid within the pleural space has caused compression atelectasis, resulting in the non-aerated lung becoming flattened or triangular in shape. In a live video, this lung undulates back and forth, flapping around in the surrounding pleural fluid. So to summarize, with normal lung, we expect to see a hyperechoic line of the pleural surface with reverberation artifact deep to it. We may see some comet tails in healthy or diseased horses. It's a very non-specific finding. And consolidation can look like focal areas that are hypoechoic, hepatized lung, or compression atelectasis. Thank you guys for watching this video review of equine thoracic imaging. I hope that you learned something and you're ready to apply this to your clinical cases. If you have any comments, questions, or suggestions for future videos, please leave them below, and thank you for watching.